Yes, ma'am.
We are live.
Okay.
Please start.
Dr. Karthika is here.
Yes, ma'am. Here, ma'am.
Why is it echoing so much? Okay. Good evening, dear friends. I welcome you for the IFS South Tamilnadu Chapter Monthly CME. Actually, this meeting is scheduled for the April because we were a little busy with the TNFOG annual CME. I was not able to get it done the last week of April, which we usually schedule it in the last week of April. So I just got it done on 1st of May. So we'll have another meeting in the May as well. Dr. Ramni is logged into another meeting. Usually she gives the welcome address for everyone, being the patron. She'll join us shortly. Now let's start the meeting with the prayer song. Sagati, the prayer song, please.
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
On behalf of, no, the first one will be Sitara. On behalf of the Tamilnadu South chapter of IFS, I welcome all of you for this evening's meeting. Last month, we had a meeting on March 27, and the topic was decoding adenomyosis. It was the ultrasound insights and clinical correlation by Dr. Mamta Deendayal. She had an exhaustive talk lasting for about 45 minutes to 1 hour. Following that, we had Dr. Ramni telling us about the management of infertility in adenomyosis. We had about 45 participants and a lot of interactive session was there following that. And it was a good meeting. So today we move on to poor ovarian response or reserve. And that's a wide topic by itself. So I invite Dr. Sitara to tell us about whom do we call as poor ovarian reserve. And to introduce Dr. Sitara, she is trained in infertility. She had her FRM degree from Simar, Cochin. So today we have two people from the same school. Okay. She had also done her FRM from Simar, and Dr. Karthika is a consultant from Simar. So I'm happy to have them both here and very eagerly waiting to know more and more about how to manage these poor ovarian response people. Over to you, Sitara. Tell us about poor ovarian reserve and classification and all that. Thank you.
Thank you so much, ma'am, for the introduction. Good evening, everybody. I'll just share my screen now. Is the slide visible now?
Yes, ma'am.
Am I audible?
Yes.
Yes.
You can be a little loud.
Yes, ma'am, I will. Good evening, everyone. I would like to thank Chitra ma'am and Ramani ma'am for this wonderful opportunity to be present in this platform alongside my teacher from Sumar, Dr. Karthika ma'am. Today is all going to be about poor ovarian reserve. So understanding poor ovarian reserve is not difficult, but there are a lot of dilemmas when it comes to its management. I will be dealing with the definitions, classification, and the diagnostic challenges in describing poor ovarian reserve. All the guidelines are taken from ESHRE, ASRM, and Indian Fertility Society. So we need to know about 3 terminologies in this chapter, like the movie RRR. So it is reserve, response, and the responders. So let's talk about the first R. What is ovarian reserve? It is nothing but the number of oocytes remaining in the ovary. So the ovarian reserve, the quantity, and the number are all the same, but it is different from the oocyte quality, which relates to the potential of a fertilized oocyte to result in a live born infant. So the quality versus the quantity, they go hand in hand. Now, knowing what is ovarian reserve, how does it affect the fertility? A female fetus at around 20 to 24 weeks bears 6 million primordial follicles, but at birth it is around 1 to 2 million primordial follicles, and during puberty it is around 5 lakh primordial follicles. What happens there is follicular atresia and ovulation, which result in a slow depletion of oocyte number over time. We all know very well about the ovarian cycle. So declining ovarian reserve is the rule. It is a fact. But why are we so concerned about the number of oocytes? Because age and the oocyte number determines approximately how many euploid blastocysts will be recovered. So when the age is around less than 35 years, studies say that 4 M2 oocytes are required to form 1 euploid blastocyst, and between 35 to 40 years, it says around 7 M2 oocytes for 1 euploid blastocyst, and more than 40 years, it says around 15 to up to 20 M2 oocytes are required to form 1 euploid blastocyst. So what is ovarian response? So coming to the second R, which is the response. Ovarian response refers to the quality and the quantity of follicular response and oocyte yield during ovarian stimulation. This response is assessed through ultrasound scans to measure the follicle development and by hormone levels. Ovarian response is critical as a metric of success of ART procedures, as the number of mature oocytes retrieved is strongly associated with the live birth rate. Coming to the final R, which is the responder. Success rates of IVF or ICSI still remain low in a subpopulation of women who do not respond optimal to ovarian stimulation, known as poor ovarian responders. So what is poor ovarian response? Garcia et al. In 1983 first defined the concept of the threshold of individual ovarian response to ovarian stimulation and its importance for successful outcome. Subsequently, many authors have fine-tuned and have attempted to quantify the response and define poor ovarian responders in terms of number of oocytes retrieved in the previous IVF cycles, or the FSH E2 levels, depending on the basal AFC, the markers of inhibin B and AMH levels, and response to clomiphene citrate challenge test. From the ESHRE consensus in 2011, the definition presented here in this consensus represents the first realistic attempt by the scientific committee to standardize the definition of poor ovarian reserve in a simple and reproducible manner. The Bologna criteria were introduced in the 2011 ESHRE consensus meeting, which included 3 criteria. Number 1 is advanced maternal age of more than or equal to 40 years or any other risk factor for POR. Second is previous poor ovarian reserve, which means less than or equal to 3 oocytes retrieved in a conventional IVF stimulation cycle. Third is abnormal ovarian reserve biomarkers are the AFC and the AMH, where the AFC is less than 5 to 7 and the AMH is less than 1.1 nanogram per ml. At least 2 of the above following criteria, if present, then they are notified as poor responders. Or 2 episodes of poor ovarian reserve after maximal stimulation are sufficient to define a patient as poor responder in the absence of the first and the third criteria, which is advanced maternal age and abnormal ovarian reserve marker. However, patients of advanced age with abnormal ovarian reserve test may be classified as poor responders, since both may indicate reduced ovarian reserve and act as a surrogate of ovarian stimulation cycle outcome. In this case, the patients should be more properly defined as expected poor responders. Since we have a consensus with Bologna criteria, then why do we need the Poseidon criteria? Why did it evolve? The heterogeneous phenotype of patients and uncertainty of clinical response in specific populations of patients with poor ovarian reserve introduces methodological challenges in implementing the Bologna criteria. Poseidon criteria hence was introduced in 2016 based on additional 2 parameters, that is the total oocyte yield from the previous IVF cycle and the presence of normal ovarian reserve findings. This helps to stratify and categorize patients with POR. It is based on women's prognosis for live birth through IVF or ICSI, thus stratifying women into unexpected and expected poor responders based on the oocyte yield in previous IVF cycles and ovarian reserve. It further classifies women based on age criteria also. So coming up to the Poseidon criteria, which we regularly use in our practice, where it is grouped in where the women are grouped into 4 groups. It is group 1, group 2, group 3, and group 4. Group 1, and all the parameters used here are age, ovarian biomarkers like AMH and AFC, and the subgroup where in group 1 and group 2, which I'll explain. So group 1 is age less than 35 years, and AFC more than or equal to 5, and AMH more than or equal to 1.2. Group 2, age more than or equal to 35 years, AFC more than or equal to 5, and AMH more than or equal to 1.2. Group 1 and Group 2 are further subdivided into 1A and 1B depending on the response of the response from the previous IVF cycle, the number of oocytes retrieved. So Group 1A is less than 4 oocytes retrieved in the previous cycle, and Group 1B when 4 to 9 oocytes are retrieved. Coming to Group 3, where the age is less than 35 years, AFC is less than 5, and AMH is less than 1.2. And Group 4, where age is more than or equal to 35 years, AFC less than 5, and AMH less than 1.2. A little confusing. Easier way to remember, Group 1 and Group 2 are suboptimal or low oocyte number patients, where Group 3 and 4 are expected low oocyte number patients. Group 1 and Group 3 are less than 35 years, and Group 2 and Group 4 are more than 35 years. So what we expect from these Group 3 and Group 4 patients is few embryos are generated, following which a reduced cumulative live birth rate. But catchy point here is that Group 2 and Group 4 being more than 35 years, where the aneuploidy rate in the embryos are little higher, where Group 1 and Group 3 have low aneuploidy rate in the embryos. These criteria aid in tailoring and optimizing the treatment strategies, guiding clinicians in choosing the most appropriate interventions based on individualized patient characteristics. So the prevalence of poor ovarian reserve or diminished ovarian reserve is an increasing trend. Poor ovarian reserve has an estimated incidence of 9 to 24% among patients undergoing ART procedures. Data from ASRM or SART, the Society of ART, shows that more than 50% of the 14% of the initial cycles cancelled may be attributed to poor response. And according to the same ASRM SART 2011 database, diminished ovarian reserve accounted for over 26% of the IVF cycles. And over 30% of these patients exhibited poor ovarian reserve, which we can expect to increase still more in the coming years. So what are the markers of ovarian reserve? Ovarian reserve markers play an important role in diagnosis and prognosis of poor ovarian reserve. So the reserve markers are, we can classify it as biological or clinical characteristics, where age, female age is the important factor, followed by menstrual cycle characteristics. Next is biochemical markers, where it can be further divided into static and dynamic markers. Static markers, where there are two cycle dependent and cycle independent markers. Cycle dependent markers, which can be checked during the early follicular phase, are FSH, E2 and inhibin B, and AMH being the cycle independent marker, which can be measured anytime during the menstrual cycle. Next is dynamic markers like clomiphene citrate challenge test, EFORT and GAS, which we'll discuss later. And biophysical markers are through ultrasound. So the three markers which we see through ultrasound are basal antral follicle count, ovarian volume, and ovarian blood flow. The last would be histological ovarian biopsy, which we don't do these days. So female age, which is useful for discussing prognosis and treatment plan, as it is an indirect measure of oocyte quality. So we can see in this chart that the optimal fertility is between 20 to 30 years, and there is a decrease in fertility between 30 to 40 years, and further on there happens irregular cycles and end of fertility leading to menopause. So there are age which determines the fertility incidence, and then this chart I found in a study where it compares age with that of the AFC count. So when we see the 50th percentile, which is the center line, purple line, you can see that during 20 to 30 years, it is around 10 to 15 in count, and then it further reduces. And this is again an interesting picture which shows that the pregnancy rate decreases with age. So ovarian reserve correlates inversely with age, but there is a considerable variation in ovarian reserve among women of the same chronological age. Young women with low oocyte number can have a better oocyte quality, and older women with a good oocyte number can have an age-appropriate reduction in the oocyte quality. So why this age is so important is that it reduces the spontaneous fecundity, it reduces the oocyte number, it reduces the embryo number, it reduces the embryo quality, it reduces the pregnancy rates with infertility with advancing age. And the most important factor is that it increases the aneuploidy rate with advancing age. Next, coming to folliculogenesis, we all know the primordial follicles moves to primary follicles, then forms the secondary follicles, and then will be small antral, and then the follicle develops depending on the gonadotrophin response. So what happens here is that two hormones are secreted. One is AMH and the inhibin B, which are considered as a marker of ovarian reserve. So inhibin B and AMH are glycoprotein hormones produced by the small antral, small ovarian follicles, and therefore are direct measure of follicular pool. As the number of ovarian follicles decline with age, both AMH and early follicular phase inhibin B concentrations decline. This decrease in inhibin B concentration will have a negative feedback mechanism, causing a resultant increase in the pituitary FSH secretion. So in turn, this early increase in FSH levels stimulates an early onset of new follicular growth and an increase in E2 concentration, ultimately decreasing the length of the follicular phase and the overall cycle. A clinical characteristic which we studied in the measure of ovarian reserve test is menstrual cycle characteristic. So there will be, when the patient complains of shorter cycles, prior to that, if she had a normal cycle length, then we have to think about a point leaning towards diminished ovarian reserve. Coming to basal serum FSH and E2 levels. The basal FSH level is measured on either day 2 or day 3 of the menstrual cycle, and when it is elevated, it determines diminished ovarian reserve. However, FSH levels have significant inter and intra-cycle variability that limits the reliability of a single measurement. Hence, elevated basal serum FSH is a specific but not a sensitive test for diminished ovarian reserve. Next, basal E2 levels sometimes cause a misinterpretation of the test and should not be used to screen diminished ovarian reserve. Coming to the anti-Mullerian hormone. AMH is produced by the granulosa cells of the early follicles and are gonadotrophin independent and therefore remain relatively consistent within and between the menstrual cycles in normal, young, ovulating and women with infertility also. AMH levels may be decreased in women currently using hormonal contraceptives and should be interpreted with caution in these patients. As well as it can be measured during a patient is on down regulation, and it says that GnRH agonist doesn't affect the AMH values. AMH is a more sensitive measure of ovarian reserve than FSH and tends to decline before FSH rises. AMH is a gene expression and the total AMH protein is increased until a follicle is going up to the size of 8 millimeters. And an in vivo modeling in humans have confirmed that 5 to 8 millimeter follicle contribute to about 60% of circulating AMH concentration. Thus, AMH has largely replaced basal FSH and E2 level testing as a biomarker of ovarian reserve, and it has been strongly recommended as a predictor of poor ovarian reserve. Coming to the dynamic test, clomiphene citrate challenge test, the exogenous FSH ovarian response, sorry, it's not reserve, it's response test, and the GnRH agonist stimulation test. These are different tests where we put in some hormones and see the prior and the post values of certain hormones, but these tests are considered are not recommended in a daily practice. But for theoretical purpose, clomiphene citrate challenge test, we check for the day 3 FSH levels and then give clomiphene citrate 100 milligram OD for 5 days, and the very next day after the completion of the clomiphene citrate, we do a FSH level. We will find a abnormally high value in a patient of diminished ovarian reserve in the post clomiphene citrate FSH values. And the EFORT is exogenous FSH ovarian response test, where the day 3 inhibin level has been checked, and then we administer 300 international units of FSH, and the post 24 hours later we see a inhibin level. The post level minus the pre level of the inhibin B values, when it is more than 110, it says that it is a good responder. And the gonadotrophin agonist stimulation test, where we give a down regulation either with a buserelin or a leuprolide acetate and check for the FSH and the estradiol levels before and after 24 hours of treatment. And if the changes is less than 180 or FSH is less than 9.5, it says that it is poor ovarian response. Coming to the important factor next is basal antral follicular count. It presents that the recruitable cohort of follicles in a cycle and correlates it with the ovarian reserve, that is the primordial follicular pool. So it is the most evaluated ultrasound marker for predicting ovarian reserve. So follicles more than 2 millimeters are sensitive to gonadotrophins and are termed as recruitable follicles. Basal scan for AFC is done on day 2 or day 3 or maximum day 4 of the menstrual cycle, and it has been counted by sweeping technique, where the follicles between 2 to 10 millimeter are counted in a total number of follicles between both the ovaries. And it is done using a transvaginal ultrasonography. So assessment of basal antral follicular count is considered as a strong recommendation in the prediction of poor ovarian reserve, but the ovarian volume and the ovarian blood flow is uncommonly used for clinical prediction, given the high inter and intra-cycle variability and general lack of sensitivity, as the evidence is scarce. So how do we select the marker of ovarian reserve? As we said, AFC and the AMH are good markers, where low AFC and low AMH predicts low ovarian reserve. And we have talked about the values. So AMH levels appear to be a more sensitive marker compared with early follicular phase hormone levels. AMH tends to decline before FSH rises. Thus, high FSH is also a specific marker for DOR, but secondary. AFC and AMH have been shown in multiple studies to be an equivalent marker contributing to each other. AMH testing is simple but expensive. When the results suggest poor ovarian reserve, counsel the couple about the opportunity to conceive shorter than anticipated and pursue more aggressive treatment options to achieve pregnancy. So these are the ovarian reserve tests. And now coming up to the indications where we have to do ovarian reserve testing. Number one, as a part of infertility evaluation and workup. Second, individualization of assisted reproductive technology, ovarian stimulation protocol and dosing. And third is history of premature ovarian failure or insufficiency or early menopause, polycystic ovarian syndrome, women considering elective social freezing in oocyte donors, fertility preservation before and after gonadotoxic treatment, and preoperative prior to any ovarian surgery in reproductive age women. So, do ovarian reserve tests predict reproductive potential among women with unproven fertility? Ovarian reserve declines with age, as do fertility rates. This had led to the presumption that ovarian reserve should predict reproductive potential. However, this has not been borne in any studies so far. So, in prospective cohort studies, markers of ovarian reserve were poor predictors of reproductive potential as measured by fecundability, cumulative probability of pregnancy, or the incidence of infertility. Do ovarian reserve tests predict reproductive potential among women with infertility? Based on the limited data available, it appears that the result of ovarian reserve tests are no more useful than age alone in cases, number one, in predicting unassisted pregnancy in women with infertility, and number two, nor do they offer clinical improvements over already established pregnancy prediction. So there is something called a Hunnalt model where it incorporates female age, duration of subfertility, previous pregnancy, semen analysis report and referral status to direct infertile patients into treatment or expectant management depending on their chances of spontaneous conception within 12 months. So do these markers in infertile women predict treatment success after ovarian stimulation and IUI? Women with unexplained infertility are commonly treated with ovarian stimulation using either oral ovulogens or gonadotropins combined with IUI. The goal of ovarian stimulation is to achieve multifollicular development to improve the odds of consumption. Recently, a secondary analysis of the Amigos trial, which is assessment of multiple intrauterine gestations from ovarian stimulation, a RCT that enrolled 900 women with unexplained infertility treated with ovarian stimulation and IUI, found that AMH did not predict the pregnancy rates after ovarian stimulation or IUI. In summary, the best evidence to date suggests that markers of ovarian reserve do not predict the likelihood of success following ovarian stimulation or IUI. Do these tests predict oocyte yield after controlled ovarian hyperstimulation for IVF? The ability of AMH and AFC to predict oocyte yield as well as poor and excessive response to gonadotrophin stimulation in ART has been well demonstrated in numerous studies. While both continue to show excellent promise to predict ovarian response in IVF, data do not support the use of an extremely low AMH level to defer or refuse treatment, but only to counsel regarding suboptimal response and yield. Do these tests predict pregnancy and live birth rate? AMH and AFC is used to predict the quantitative outcomes such as oocyte yield and ovarian responsiveness, but the same is not true for qualitative outcomes. AMH as an independent variable is only a weakly predictive of pregnancy at best. AMH is clearly an important part of the puzzle, but there are many more variables like female age, sperm parameters, the sperm quality, embryo development, stimulation protocols, the procedure, and the lab techniques also play a significant role in pregnancy and live birth rate. Coming to combined ovarian reserve tests. Attempts to improve the predictive value of multiple ovarian reserve tests have not been found to be beneficial. Despite a lack of evidence that more ovarian reserve testing improves outcomes, it is common for patients to have multiple screening tests performed. In addition to adding to the overall expense, discordant results may complicate the management protocols. So coming to the summary, when carrying an infertile couple, clinicians use age and diagnosis to counsel and tailor the treatment plan. Thus, age is a much stronger predictor of reproductive success than is ovarian reserve alone. Number two, the goal of ovarian reserve testing is to add prognostic information to the counseling and planning process to help couples, because ovarian reserve test is testing only quantity and not the quality of the oocyte pool. It is important to emphasize that ovarian reserve test should not be used to deny patient access to ART or other treatments. Evidence of diminished ovarian reserve does not necessarily equate with inability to conceive. Currently, AMH and AFC are the most sensitive and reliable markers and are good predictors of oocyte yield and ovarian responsiveness in IVF, but are poor independent predictors of reproductive potential. Extremely low AMH values should not be used to deny treatment in IVF. Dynamic test does not improve test accuracy and hence not used. Combined tests do not consistently improve the predictive ability over that of the single ovarian reserve markers. Poor ovarian response to maximal stimulation during IVF procedure reflects diminished ovarian reserve, and further ovarian reserve testing is unnecessary and not mandatory. Decisions regarding oocyte cryopreservation should be based on a woman's reproductive plans and age. Consecutively, markers of ovarian reserve should not be used to promote a planned oocyte cryopreservation. I would like to conclude by saying all healthcare providers are encouraged to speak with their patients about their reproductive plans at all stages of reproductive life. Opening this dialogue and educating patients facilitates their decision making a little earlier. Thank you.
Thank you, Sitara. I can understand from the last line what it is to be an infertility specialist and how, how sick you feel when you see somebody, having had many cycles of ovulation induction elsewhere, and when they reach to you asking for babies with IVF at least, and you have nothing to really offer them. So I understand all these tests will tell us to counsel patients better about what would be their chances of getting pregnant with a relationship with only the oocytes that you would get. and the other factors add on the fuel to the fire. So here we go with Dr. Kartika, who will tell us how to manage these patients who come to you with poor ovarian reserve. I think Dr. Ramani has joined us, and she'll also be happy to welcome you, Kartika, along with me. Very happy to have you here this evening. Where is her CV? She works in Simar, and I was very happy the moment I called her. She said, "Yes, I'm ready. I will do it for you." So because it's a webinar, I'm able to get all these people from different places to do this for us, and I'm happy to have you here, Kartika. Yes, you can go on. Thank you. What happened? Slides are moving.
Hi, am I audible?
Now you're audible. Yes.
Good evening, everyone. First of all, I would like to thank Dr. Chitra ma'am for giving me this opportunity. And Sitara, that was an excellent introduction to the complexities of POR.
Thank you.
Now that we have covered the what and why behind POR, let us now turn to how. That is how we can tailor our interventions and improve the outcomes and support the patients with individualized care. So the topic given for me today is optimizing the ovarian stimulation protocol in POR, what works best. So I would like to put it like the ovaries go into a state of introvertism and they just refuse to come out and play. That is exactly what is POR. So now imagine you are planning a big party. You have sent out so many fancy invites, that is your gonadotropins, you have prepped up everything, but only 3 guests show up. So that is POR, right? So why do our ovaries always have to be so mysterious? Why does 450 international units sometimes give fewer eggs than 150 IU? Why do our ovaries ghost us mid-cycle? And where do these follicles go in between the scans? So today, we will decode this ovarian mystery with science, strategy, and a bit of planning. So why actually there is a silence? Is it because of the age, the genetics, autoimmune problems, unexplained infertility, or previous insult to the ovary, such as any surgeries, chemotherapy, radiotherapy, or is it just bad luck in that particular cycle, or bad luck for the patient? So I would say never blame it on bad luck, because POR is very common and if affect about 1 in 5 women undergoing IVF. That is, the incidence is around 9 to 24%. It's common, but unfortunately it is unpredictable. But the good news is we are not alone, right? Because all our colleagues would have been exposed to this poor ovarian response. Now coming to the classification of POR, Sitara has already explained about the Bologna and the Posidon criteria. Most of us still follow the Bologna criteria because it's easy and widely adopted. But Posidon gives the more detailed and personalized prognosis, though it is slightly complex. My talk today will be more based on this Posidon criteria. So we know that Posidon has 4 groups, group 1, 2, 3, and 4. So 1 and 2 are unexpected poor responders, whereas group 3 and 4 are expected poor responders. So now coming to the most difficult part, that is managing the poor responder. So predicting the ovarian response before starting the stimulation itself is the only way you can administer efficient and safe treatment. So how to identify this at-risk population? Definitely the elderly, those with high FSH, low AMH, those with small ovaries, previous poor response, previous insult to the ovaries such as any surgery, chemotherapy, radiotherapy, genetic defects, autoimmune disorders, single ovary, smoking, and unexplained infertility. Now that we have identified this at-risk population, now how to individualize their controlled ovarian stimulation. So whenever we have a poor response, our unofficial motto for every reproductive medicine specialist is increase the dose of gonadotropins. So it is like you turn up the volume of a silent phone and you hope that somebody will pick up the phone. But the spoiler is sometimes they don't. So our goal should not be to increase the dose, but our goal should be to maximize the number of mature oocytes, optimize the quality, and minimize the patient burden and cost. Although the most successful and the ultimate treatment of a POR is egg donation, the women are mostly reluctant to consent for egg donation upon your initial consultation. So they keep on requesting the alternative solutions despite the low odds of success. So coming to the protocols, since the era of 19th, we know that gonadotropins with gonadotropin agonist started on the late luteal phase of the previous cycle is often considered the best protocol of choice for normal responders. But in poor responders, this may induce excessive ovarian suppression. So in POR, the option is to reduce the length of the suppression. Either you can lower or stop the agonist which you initiated in your luteal phase. So we come to the modified GnRH agonist protocol. Here we reduce the length of the suppression by decreasing the duration of the agonist. So we have different options, that is the short, ultra short, and the microdose flare, where we start the agonist for a short period, or we start at a higher dose and then lower the dose. So this is actually effective for patients with very low reserve who may benefit with the endogenous FSH and LH surge. Or you can either stop the agonist which you started in the previous luteal phase. But the risk is there is a variable follicular response, so more monitoring is needed, and sometimes you need to add an ANTAC to prevent the premature LH surge. Then comes our antagonist protocol, most commonly used in POR due to its flexibility and lower suppression. Here you start gonadotropins at a higher dose of 300 to 450 IU. You start ANTAC either on day 5 or day 6 or when the leading follicle is more than 14 mm. And when you are giving an ANTAC, you can even consider a dual trigger with an agonist or low HCG. This helps us to increase the yield of the stimulation. So there are more protocols which are coming up. One is the mild stimulation protocol, especially in younger patients with low reserve. You give it along with oral ovulogens plus low dose FSH or HMG. The cost for the patient drastically comes down. The tolerance is better, so better compliant. It may yield fewer eggs, but the quality of the eggs are going to be extremely good. Then you have the natural or the modified natural IVF cycles. These are used in very low responders. You use minimal medicines and trigger when the follicle is ready. And occasionally you can combine it with IVMM also. Other protocols are estrogen priming protocol, where you give estrogen in the luteal phase, suppress the FSH rise, and you get a synchronized cohort for stimulation. You can combine it with ANTAC protocol to prevent again the LH surge. This is especially useful in group 2 and 4 patients. Then the recent one, which is the double stimulation, which is very commonly spoken about in the current era, where you stimulate the patient in the same menstrual cycle twice, both in the follicular and the luteal phase. This is suitable for very low reserve patients, that is Posidone 3 and 4, where you need to accumulate the oocytes. You have a retrieval in both the phases, which again reduces the chance of waiting for the next cycle. So our stimulation protocols does not stop only with gonadotropins. We have a range of adjuvants which are supposed to strengthen the effect of this exogenous gonadotropins. Sometimes when the patient asks, ma'am, what can you offer me more? I have failed once, I have failed twice, I want to increase the number of oocytes. We give a set of medicines for them, adjuvants. So sometimes it is like running a wellness spa for your ovaries, no? But if it can help the follicles feel pampered enough to grow, then why not try it? So we have a wide variety of adjuvants coming up. The most common one used is the androgens, that is the DHEA or the testosterone gel is also available. It increases the intraovarian androgens, so increases the FSH receptor expressions, increase insulin growth factor 1, decrease the follicular atresia. You start with 75 milligram per day, either 2 to 3 months before the stimulation, because it takes time, because it has to be converted to testosterone. Then you have the testosterone option, which is a gel which you start at least 21 days prior to your stimulation, more rapid androgenic effect. And some improvement has been shown in the antral follicle count, your yield, and the clinical pregnancy rate, especially in Posidone group 3 and 4. Then you have the growth hormones, which improve the oocyte quality and the granulosa cell functions. They are increasing the insulin-like growth factor 1, enhances the granulosa cell proliferation, improve the FSH action and the mitochondrial function. You start it either early before stimulation or from the day 2 of a cycle, usually 4 international units to up to 8 international units per day, but it adds to the cost of the stimulation. It gives mixed results and can be useful in elderly patients. Even Cochrane review suggests low to moderate quality evidence of its benefit. Another one is the recombinant LH, where LH stimulates the theca cells, increases the androgen production and the granulosa cell estrogen conversion. It supports the follicular steroidogenesis. So it is usually added from the day 6 of the cycle, especially in elderly women, which is thought to improve the oocyte maturation and endometrial receptivity. Another one is antioxidant, your CoQ10. It improves the ATP production and the mitochondrial activity. The dose is 200 to 600 milligram per day orally. Again, started 2 to 3 months before IVF stimulation. It is thought to improve the oocyte quality, fertilization rate, and the embryo development, especially in the elderly group. Now, you even have ART calculators. So, you usually you identify the suboptimal responders by static tests like AMH, AFC. But now we have dynamic markers, which are the follicular output rate, which is the number of oocytes retrieved divided by the antral follicle count into 100. So if the FOI is less than 50%, then you can group them as a hyporesponder, even with a normal AFC. So for example, the patient got only 2 oocytes in the previous cycle. She is having a AFC of say 8 to 10, I would say, or an AMH of 1.7. Okay, now she got 2 oocytes and her AFC was 10. So 2 out of divided by 10 into 100, you get 20%. So her FOI is less than 50%, which shows that she is a hyporesponder. So this helps us in the clinical decision making that we need to adjust a gonadotropin dose, consider adding adjuvants in the next stimulation, and even you can assess your stimulation protocol effectiveness. Then comes your oocyte sensitivity index or the ART index, which measures the ovarian responsiveness, where you see the number of oocytes retrieved to the dose of gonadotropins what you have given. So it shows the hyporesponsiveness and helps in identifying women who may benefit from adding your adjuvants like the androgen priming, your growth hormone, antioxidants, etc. So having known the gonadotropins and adjuvants, we will see now in each group how to approach them in a more individualized manner. So in group 1, which are the young, good reserve and patients which show a poor response, that is the unexpected poor response group. The approach will be a GnRH antagonist protocol. Here we think they are young but still not responding. So maybe the receptors are just picky. The FSH receptor screening can be done in these patients to rule out receptor polymorphism. You start with a higher dose of gonadotropins. If needed, you can add recombinant LH and can add dual trigger, that is agonist plus HCG for the oocyte retrieval. Coming to the second group, the group where the time is ticking, but the ovaries are looking fine on paper. The ideal protocol in this patients will be an ANTAC protocol with high-dose gonadotropins with a dual trigger for final maturation. You can consider adding adjuvants. Even a dual stimulation, that is follicular plus luteal stimulation, can be considered because one chance is not enough anymore for them. So in a particular cycle, you stimulate them twice and gather as many follicles as you can. Now, group 3, which are the young patients, but they have a low reserve. In this group, you can try mild stimulation or an antagonist protocol. Aim at retrieving every available follicle. The dual stimulation will help in a cumulative oocyte collection and preferably avoid long protocol in such patients because it can cause oversuppression. The younger group are the age which we believe that even if you get a few eggs, it can produce wonders. Now the group 4, it is the least favorable group, I would say, because they have low quantity as well as quality. Their approach will be to start on an ANTAC protocol with high-dose gonadotropins. Dual stimulation can be strongly considered. Adjuvants definitely in these cases to improve the outcome. And this is the group where you have to discuss about egg donation early on. Because when we fail plan A, we don't sit and cry. We go for plan B, we go for plan C, then donor eggs, because donor egg is the ultimate fauna friend in our ART world. Now, having got this oocytes in hand, taking care of them in the lab is also important. So what are the measures we need to do in the lab? Handle them gentle with minimal pipetting stress because they are few and very fragile. I would always prefer an ICSI to maximize the fertilization. You can add on with the advanced sperm selection techniques to improve the fertilization and also to reduce the DNA fragmentation impact on the poor quality oocytes. Whether to keep them for extended culture, again, suboptimal embryos. So early transfer will be better in those cases. Even PGT and PGTA are not recommended in this embryos because they are very limited in number. And I would always prefer a sequential media for better embryo development. So you have taken care of them in the lab. Now tailor the embryo transfer. So whether you want to go for a day 3 or an extended blast culture, in POR patient, it is often preferred to have a early transfer because there can be a possibility of total embryo arrest in extended culture. If you have more than 2 or 3 good quality day 3 embryos, then even you can consider growing them up to blastocyst stage. Now, there are many newer trends coming up to improve the oocyte quality and number. One is the ovarian regeneration with your platelet-rich plasma, stem cell therapy, and AI prediction of your ovarian stimulation, your selection of the best embryo for transfer. All this are coming up in a new way. Yes, in these patients, the numbers are less, but they are never zero. Even you get few good quality embryos. Miracle pregnancies are possible. So it is not only about the quantity, it is about one perfect follicle which perform well. So although it is frustrating to both the patient and the doctor, there is no solid data as of now to recommend any magic bullet protocol for patients with POR. So the take-home message is personalized treatment planning. In group 1 and 2, focus on the quantity, and group 3 and 4, focus on the quality. Tailor your protocols per the Posidon group. Consider mild stimulations than your conventional methods. Our ovaries don't always follow protocols. They are flexible. Only when alternate solutions prove unsuccessful, consider other options, counsel the patient, and if they are willing, the next option of treatment will be an egg donation program. So thank you.
Thank you, Kartika. When will you choose testosterone as the adjuvant or the pre-treatment for these patients who are pure?
Ma'am, I am not a fan of testosterone because I had a few bad experiences with testosterone gel. So I don't advocate testosterone gel at all.
What bad experience in the sense?
I have tried in patients testosterone gel. But then the previous cycle, if they had responded and given me few eggs, even that did not come in the subsequent cycles. So I have tried only for very few patients and I have completely stopped using testosterone.
You believe in DHEA?
DHEA, yes, I give it very routinely. And I have seen it works in certain group of patients, especially I would say Posidon 3. 4 is very doubtful, but Posidon 3, I would highly recommend giving DHEA.
This PRP and all that, have you tried PRP?
PRP only if the patient is asking for a PRP. Otherwise, again, though I have seen so many studies and people promoting PRP, in my experience, whichever patients, even one or two young patients which we have tried PRP have worked. But otherwise, in elderly group, I think there is no point in giving PRP.
Again, here that's the thing. For younger patients, it may work better. For older, again, it may not. How long do you wait after the PRP?
Minimum 2 to 3 months.
2 to 3 months. 3 months.
Okay. But I have not seen a rise in an AMH or anything. But in younger patients, yes, maybe a slight
number of follicles maybe.
Yes, maybe. But again, abortion rates are high. Even if you get a pregnancy, it doesn't end up in a live birth rate. That's
what. Somebody on the chat box has asked about how do you do antral follicle count? Can you repeat? That was for Sitara, I suppose. They wanted to know how to do the screening for antral follicle count.
So antral follicle count is a basal antral follicular count. It is done on day 2 or day 3 or maximum day 4 of the menstrual cycle. The method is called the sweeping method and it is done by a 2D real-time transvaginal ultrasonography. So we identify both ovaries and we fix one of the ovary, measure 2 measures for the ovarian volume and then sweep from one end of the ovary to the other end of the ovary, counting the number of follicles which are 2 to 10 millimeter in diameter. How do we know that it is 2 to 10 mm in diameter? Is that first find the largest follicle and measure so that we will know whether it is less than 10 millimeter and then go around and from one corner to the other corner just by sweeping, we just have to measure in one direction. That's it.
Thank you. Kavya wanted to know whether follicular and luteal stimulation is the same as dual stimulation. Kartika.
Ma'am, question, ma'am.
Follicular and luteal stimulation, is it the same as dual stimulation?
See, dual stimulation, what we do is we combine both follicular and luteal. There are separate follicular phase stimulations. There are separate luteal phase stimulations, which we call the random start stimulations. But when we combine both together in a single cycle, then you get a better yield of follicles. So we routinely use dual stimulation protocols where we give CC plus a low dose HMG in the follicular phase. We take the follicles with the first go, only the follicles which are above 13-14 millimeters in size. The rest of the smallest follicles we don't touch. Then after 48 hours, we call the patient and again start the second set of stimulation where we start with a little higher dose of gonadotropin, sometimes 225 to 300 international units, and then you continue. Though our studies say that you need not add an antac because of the high progesterone, there will be no LH surge. But sometimes it is scary not to add progesterone, your antac. So we do add antac towards the last of the cycle before the pickup to prevent any LH surge if it occurs.
Which part of it? Follicular phase or the luteal phase?
In the follicular phase, it is only CC we continue till the pickup.
Okay.
In the luteal phase, we add antac.
Okay, you continue CC till the pickup.
Till the pickup.
That acts as the...
Till HCG, we give CC 100 mg.
Okay.
Actually, the dual stimulation gives very good results.
Oh, you get at least the number. In one cycle itself, you get that
And
number.
even pregnancy rates are very good with...
Do you think the oocytes that you get during the luteal phase is better than that you get during the follicular phase?
Initially, when we started the stimulation, we felt that the follicular phase, I think Sitara was there during that time. We always felt that the follicular phase fluid, the follicular phase oocytes or the embryos which we get were very good, and the pregnancy rates were very high with those. Whichever patients we didn't get follicles in the first phase and we got in the luteal phase, actually pregnancy rates were very less. But currently, whichever patients we are doing, the luteal phase embryos are giving us pregnancies.
Better.
So again, we are kind of so we are currently trying to compare. We are doing a study of the cumulative pregnancy rates, and then we will see how it is going.
Okay.
Madam, how do you counsel them before itself for this dual stimulation? Like on what criteria?
See, again, it is patients who have already failed at least 2 times. Okay, so when you counsel them, it is couple who are not ready for a egg donation program. So they are desperate to do whatever you say, to be very frank. Okay, and cost factor is very important when you counsel the patient because it is 2 pickups. They have to pay 2 times plus 2 anesthesia, everything. You have to prepare the patient in advance. And mostly it is...
and do we also do hormone analysis before starting the second stim?
No, we don't do because already the hormones will be very high. Because the first pickup, E2, FSH, everything is going to be high. So there is no point in doing a second cycle hormonal profile. The second cycle is usually continued as such. In the first cycle, we do because we are giving CC only till your pickup. So when you're giving CC, the LH should be monitored correctly because if at all we see a LH rise, we do add maybe 1 or 2 days of antac just because before pickup. Otherwise, in the second half, you need not do a monitoring because your progesterone, everything is going to be high.
But in the first cycle, you do add antac, right?
First cycle, we do CC.
No need of antac.
No. Only if there is an LH surge, you need to add an antac. Otherwise, CC.
Let's say you had to add antac. Then, if you had to add antac, seeing the LH rise, then in the second half, what do you like? Also, you do the antac?
Yes. Second half, it is basically because we are scared that the follicle.
Yes.
But studies, there is no need to add.
After doing the pickup, like when you see after 48 hours, the ovaries are a little cystic.
Yes. It is very difficult to see whether there are follicles coming up or no, because the ovaries will be full of hemorrhagic cyst.
Yes. So how do you now differentiate, like when you see for the new follicular growth?
Yeah, when you call them after 48 hours, it is very difficult to say whether you have a small follicle, whether they are hemorrhagic. It is very difficult. But once you start the stimulation and call them, you can actually appreciate the hemorrhagic follicles and your normal follicles very clearly.
Okay.
This is, the hemorrhagic cyst you can identify, and the follicles will be like clear
Yes.
cyst.
It is
So
like
it's
basically
very
how you
easy
do
to
the
detect.
follicular study in the follicular phase, no? Same like that you can see in your luteal
Luteal
phase.
phase also.
Yeah. Once they start coming up, it is very easy to differentiate.
So most of these this poor ovarian reserve patients will have a natural cycle. Like, do you really put them on estrogen prior to your stimulation?
Estrogen I hardly use, ma'am. I am not a follower
How
of
do
it.
you synchronize, madam, then mostly?
We either give a depot, which is a long acting protocol.
Okay.
Otherwise, I do a day 2 scan, and then if follicles are all suppressed,
Natural
then we go
cycle.
for a direct stimulation. Yeah.
No, if
Siddhar is
there is
known
a
for their
cyst,
long acting
most of these PORs, they usually show up as cysts
Occasionally, if
with
I
low
see a
E2,
cyst, I
with
put them
low
on 1 month of
basal
pill,
E2.
and then I stimulate them in the subsequent cycle.
Achha, even then you give pills.
Yes, I don't use estrogen. And one more thing is, never compromise on these patients. Because if you see a cyst, don't get scared that how will I counsel the patient, that patient will go off. Don't think like that. Because these are patients who are had previous multiple failures. So you talk to them, be very honest with them. If you see a cyst, you tell them that I am seeing a cyst. Is unfortunately, we will have to skip this cycle. So counsel the patient. I think most of them are very vulnerable to our counseling also. So you can counsel them and they will listen to you. And
No,
most
but
of them are
this
like
cysts,
in a
madam.
desperate state. No, so they also don't want to compromise on the treatment part.
No, I just have a point, madam. If with this cyst, sometimes the E2 levels, baseline E2 levels are also very low. So would
E2 is
cyst
less, you can very well start the
Stimulate.
stimulation. I don't wait for one more cycle.
like even if the cyst is like 16 mm?
Usually, no, nothing will happen with if the E2 is normal, you can go for stimulation also. I don't
Oh,
aspirate. I don't aspirate. I don't wait. Even if it is a follicular cyst, it will be producing estrogen. If it is not producing estrogen, you can very well start the cycle. No issues.
Suppose the cyst is active, only then it is worrisome because your estrogen level is going to be high. And you really do not know what's the picture when you stimulate. But as long as the estrogen is low, whatever be the cyst size, it really does not matter.
no, ma'am, because of that cyst, it will create pressure on the other follicles, no?
Nothing will happen with that cyst.
Let the cyst grow along with the follicles.
Yes, and you can aspirate it when you're doing your pickup, you aspirate.
Okay. Thank you.
That should be the last that you pick up. I mean, when you puncture all the other follicles, the largest cyst should be the last that you will puncture. Okay. Any more questions? Thank you. Thank you very much, Kartika, for being with us today. I'm sure it's of benefit to all of us who have been looking forward to, how to manage this poor ovarian reserve patients, because that's the biggest headache all of us face today. And we want to, put as many oocytes as possible and try to get at least a few embryos for them, because everyone these days are very desperate about getting their own oocytes. But there is always one myth about coming to an IVF center. They think once they come to an IVF center, it's not going to be their own embryos.
And we know how difficult it is to get another headache.
And we are on the other side, struggling to get their embryos. They don't understand. That's the irony of the entire story. Anyway, thank you. Thank you so much. No more questions, I suppose.
I just have a question, ma'am.
Good.
Dual stimulation, which protocol is preferred? Long agonist, some patients you were saying, right? For dual stimulation, which protocol is antac or
dual? You can do only with antac.
Antac. So sometimes you said a little dose of down regulation. So is that possible?
For dual stimulation, we don't down regulate. We start in a natural cycle with an antac.
You can synchronize. You can synchronize with anything that you want to, but you don't have to go for a long antagonist. Divya Lakshmi, you want to ask?
Hello, ma'am.
Yes.
Ma'am, good evening, ma'am. I just want to ask about how about PPAS protocol for the poor responders, ma'am, like poor ovarian reserve patients, ma'am?
I have never tried in a poor responder, but we usually do it in our donor cycles. All our donor cycles are PPOS protocol only, and they give extremely good stimulation and results also. I am
Like if you
not
are
very sure with the POR. I have not come
okay,
across
ma'am.
or I have tried in any POR patient yet.
But this
Okay, ma'am.
CC
Thank you, ma'am.
Good responders, it is very good protocol.
Madam, with PPOS,
Okay.
usually the embryologist says that the oocytes are very sticky.
We never had any issue because all our donor cycles are with PPOS. I would
Even
say
I used to
100%
do
of our donor cycles, and currently we cannot take more than 7 oocytes from this. But we get very good yield from these patients, even with 150 and PPOS. So 100% of our VOD cycles are now with PPOS.
Any more doubts, questions? Okay. Thank you. Thank you very much for being with us today,
Thank you, ma'am.
Kartika and Sitara. I'm sure it was a good enlightening talk by both of you all. Thank you on behalf of IFS South Tamilnadu chapter. We look forward for more such meetings. Thank you.
Thank you.
Thank you, ma'am. Thank you, Kartika ma'am.
Thank you.
Have a great evening. Good night.
Good night. Bye, ma'am.
Thank you, Sarati, for this support